Good afternoon and welcome to today's OR Today webinar, Evacuate Surgical Smoke, Everyone Has a Right to Clean Air. Today we are joined by Richard Howard, North American Sales Manager at IC Medical. With nearly 20 years of experience exclusive to the smoke evacuation industry, Richard has a deep passion for helping clinicians and other stakeholders with the creation of a surgical smoke-free environment of care. I would just like to mention that OR Today is pleased to support two events in September. Periop Connect will take place September the 8th and 9th at the Omni New Haven Hotel in New Haven, Connecticut. For more details, please visit periopconnect.com. And the second event is the Georgia Council of Perioperative Registered Nurses annual conference, which will take place September the 29th and 30th at the Atlanta Evergreen Lakeside Resort in Stone Mountain in Georgia. For more information, please visit gacouncilnurse.org. Registration is now open for both events, so more details can be found in the handout section of your webinar dashboard, including information about our OR Today contest. Today's webinar is eligible for one continuing education hour, and you can obtain your certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. Today's webinar is also eligible for extra credits from the California Board of Registered Nurses and also the NCCT. Details can be found in the handout section of the dashboard, and also a link will be included in the follow-up survey email as well. If you have any questions, you can reach us at webinar@mdpublishing.com. Okay, let's kick off today's webinar by giving away one of our OR Today live lunch bags to the attendee that can tell me the answer to the following trivia question. August is National Eye Exam Month. What is the most common eye colour? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, our presenter today is Richard Howard. So Richard, you may begin whenever you're ready.
Thank you, Linda. Good afternoon, OR Today readership, and thank you for joining the webinar, Evacuate Surgical Smoke, Everyone Has a Right to Clean Air. The funding provided by IC Medical, and we will jump right in. There are a few learning objectives to this CEU program and webinar. Number one, we'll discuss the harmful effects of surgical smoke, or the exposure to surgical smoke, explain the benefits of using a smoke evacuation system. We'll discuss guidelines established by regulatory agencies and professional associations related to surgical smoke. And then we'll identify, how do we address the issue by identifying characteristics of an ideal smoke evacuator. And also we'll talk about some quality assurance and process improvements that you can make in your respective places of employment to comply with the aforementioned safety guidelines. And there's some new state laws too, and I'll touch on that as well. The intended audience is any registered nurse or surgical technologist or other healthcare professional or stakeholder that wants to gain a knowledge on the harmful effects of surgical smoke evacuation. This course is also available to your respective employers. If you want to offer it, just get in touch with us, and we'd be happy to do that at your place of employment as well, live and or virtually. So once we get through all of the credits, I'll jump into the introduction. So hospitals are a place for healing and care, yet the smoke that is released during surgical procedures by the use of energy devices such as lasers, electrosurgery, and the other type of vaporization, harmonic scalpels, ultrasonic devices, it creates a foul odor. And most people are familiar with the foul odor. What we don't necessarily realize is that that odor indicates the presence of airborne particles that can be carcinogenic to humans. They can be toxic. contains compounds like hydrogen cyanide, toluene benzene, other bioaerosols, and it can contain viruses like human papillomavirus and HIV. You're also dealing with blood fragments that can carry a pathogen, and certainly bacteria is of concern as well. There are other types of concerns, and we will address some of those in terms of airborne exposure and what we're dealing with here. Surgical smoke evacuation and the chemicals are one component. I like to put smoke evacuation into two components, one being 100% quantifiable, and that surgical smoke contains the same chemicals as cigarette smoke, and the second being that surgical smoke can also contain, and does also contain, potentially infectious agents like HIV, HPV, and pathogens that we just alluded to, which is less quantifiable, but of equal and perhaps even greater concern due to the potential transmission of disease. Despite guidelines from workplace authorities like OSHA and the NIOSH, CDC, AORN, and other bodies, there's still not a lot of folks using smoke evacuation. I mean, the compliance is relatively low despite the raising awareness, but that just means folks like myself and other stakeholders in this industry have work to do, and yourselves in relaying to your colleagues, what are the hazards? What are we breathing each day when we come in? For example, using an electrosurgical device on 1 gram of tissue, or ablating 1 gram of tissue with a cautery pencil has been shown to be the equivalent of inhaling 6 unfiltered cigarettes within 15 minutes. I think the hazards to staff and to any layman are well documented on exposure to cigarette smoke, which is why I think it's very important to keep that first ball open as the predominant point of discussion, because it's irrefutable and you won't run into as much debate internally, and everybody can coalesce on that, and then adding this flavor is just additional impetus for addressing the problem, which again is the pathogens, viruses, etc. What are some of the hazards? I mean, documented hazards include perioperative staff members suffering from health issues like asthma, bronchitis, eye irritation, headaches, allergies, some other problems such as carcinoma and leukemia following exposure to the smoke. One study linked surgical smoke exposure to healthcare provider during a GYN procedure, probably doing like a LEEP procedure or removing condyloma from the genitalia, getting laryngeal papillomatosis, or in other words, getting HPV in their throat. I've seen other studies of a surgeon that contracted HPV on his forehead, right underneath, or right above his mask or something like that. I can't remember exactly, but I've seen a lot of studies showing HPV moving around in surgical smoke. Another potential issue is there was one with port site metastasis, in that minimally invasive surgery on some type of cancer, and when they pulled the ports out, the cancer started to form where the port was in the body, and basically linking the spread of cancer in surgical smoke. These are just some other areas that fall into that second bucket. Again, the first bucket is one that we don't want to lose sight of either, and that's just breathing in carcinogenic gases in large parts per million, where you're breathing in smoke. And so we'll touch on some of that now. I broke this up into 6 categories here. There's more, and we could get into more of them, but some of the high level bubbles, that if we were to break down these 2 bubbles into smaller ones, we have viruses, and you can see the virus particle sizes are very small. SARS-CoV-2 would be a virus, very small particle sizes. These are nanoparticles, smaller than 0.1 micron, certainly much smaller than 5 microns, and we'll talk about why that's important in just a moment. You have bacteria, you have live cellular matter, you have nanoparticles that are really, really small in diameter, smaller than 0.1 micron, and blood fragments that can carry pathogens, and such as viruses, HIV, HPV, etc. Here's just a list of a couple of those agents. There's references cited throughout this that I'm happy to share with any interested party on request, or I can funnel that through Linda and her team, whatever works for you. So this is just a graphic depiction, and I think why this is important is because we're really going to, with this graphic, we're going to demonstrate that bubble one that I mentioned at the beginning of the call, that is unquantifiable, that is of the most irrefutable, or provides the strongest foundation to stand on as to the why we're going to use smoke evacuation, and that is the size of the particles and what that means based on chronic exposure, certainly in the health in the workplace. Those small viruses, like a surgical mask, and I'm going to talk about that 5 micron and why that's important, is a traditional surgical mask, according to OSHA and the personal protective equipment laws. A surgical mask is designed to protect the patient from the healthcare worker's bodily fluids and anybody else who's in the room. You know, that's it could be a sales rep, it could be an anesthesiologist, etc. We're wearing a mask so that the patient, when they're cut open, you know, we're not spitting into them, basically. We're not spreading disease from our mouth. What a surgical mask stops short of is blocking anything that's in surgical smoke, because surgical smoke is nanoparticles. Again, those particles are much, much smaller than 5.0 micron in size. We're looking at SARS-CoV-2 and other viruses down as low as 0.06 versus 5.0, significantly smaller, 800 times smaller. They fall under the range of what is called a nanoparticle, or an ultrafine particulate matter. It goes right through the mask. So if you wear an N95 respirator, and I'll touch on that since I'm sure somebody's asking themselves, what about a respirator? A respirator, N95, fit tested, if everybody in the room is wearing one, definitely checks one of the boxes of blocking respirable exposure to the plume. But it does stop short of ocular exposure. It doesn't do anything to protect everything else in the environment of care from potential contamination from whatever that patient happened to be carrying or whatever went airborne in the smoke. And it also doesn't stop that smoke, which can be infectious or full of toxic and carcinogenic compounds, from going airborne and quickly dropping right back into the patient, potentially spreading infection in that patient. The only effective way to address respirable exposure, ocular exposure, environment of care exposure, and patient exposure is to use a local exhaust ventilator, or what we call a surgical smoke evacuator. And we'll talk more about that later in this call. But back to those nanoparticles, those small ultrafine particles that are being breathed in respirably if you're not using an N95 respirator, which I would argue most folks are not, that are in the environment of care during surgery. What happens is they go through the mask, they go down through your trachea into your lungs, and they get lodged in the pulmonary alveoli. You're all probably more familiar with this than I am, because I didn't go to nursing school. You did, so you know what I'm referring to. And those small nanoparticles get lodged there. So the alveoli are doing their job. They're preventing that from passing into your bloodstream and moving around. However, over time, chronic exposure means a lot of that builds up, which decreases the body's ability to effectively introduce proper levels of oxygen into the body through the alveoli, which is what the alveoli is designed to do. So it's doing its job, but that chronic exposure over time can be extremely inflammatory and can lead to respiratory ailments like COPD and other types of inflammation. Inflammation in and of itself can be carcinogenic. If you're eating, donuts and trans fats in your food, they've shown that to be carcinogenic and cause cancer. Well, same thing with breathing in particulate matter, which can be carcinogenic in its nature, but even if it's dead cellular matter from the smoke, the chronic exposure, just being parts per million building up, is inflammatory and carcinogenic. So there's multiple levels of potential hazard to chronic exposure to surgical smoke. And again, that's part of that bubble one. And so I think hopefully I've covered that effectively to paint the picture as to why smoke evacuation is needed to prevent that chronic exposure. There's many peer-reviewed journal publications that deal with it, advocate mutagenicity, carcinogenicity, cytotoxicity of surgical smoke. Again, I alluded to the study that talked about the 1 gram of ablated tissue being the equivalent of 6 cigarettes. There's another article, I'm trying to remember if that is included in, it's included in here. And this was done by the Journal of Plastic, Reconstructive, and Aesthetic Surgery, which is a peer-reviewed journal, of course, where they determined the equivalent of 27 to 30 cigarettes per day on average for staff that work during breast surgery, mastectomies or plastic surgery, because of the amount of, paniculectomies, any procedure where it's plastics and they're doing a high amount of cutting and during the surgery. That's a lot of smoke exposure in a single day. Certainly over time for a nurse that does this day in and day out, 52 weeks a year. And so that's just one example of those studies that have been done. Of additional consideration, I found this very interesting, and I don't know what it means. I'm not an epidemiologist. Maybe somebody on this call is, and you can run with this and expound on it. And I haven't gone back to this in 5 or 6 years, and there may be additional research. I'd be foolish to think that there isn't. I'm just not aware of it. But last I looked at this, which is what I'm about to highlight, I mentioned the alveoli getting lodged with all that particulate matter, and the alveoli doing its job, preventing those particles from passing into your bloodstream. But they have shown that some of that particulate matter, whether it's doing it through the alveoli or through the trachea, they have demonstrated those nanoparticles in the surgical smoke to translocate into other organs of the body, right? So, the lungs, the liver. Does that mean you're going to get a disease if that patient had it? I don't know. That's above my pay grade, but I don't want to breathe it. And these are some of the reasons why the science is so robust that states in the U.S. are finally making it. There's just too much evidence to deny that there is the potential for spread of disease, and staff shouldn't be exposed to the plume while they're trying to do their job, which is predominantly patient care. Kudos to each of you for doing that. I don't know how you do it, but Godspeed. So what are some of the other negative health effects to surgical smoke? They're listed here for your reading pleasure. Some of you may have had some of these symptoms in your lifetime. They're all listed here. I won't bore you with reading through this entire list, but maybe you've had the displeasure of experiencing or knowing somebody who has. And this list is not exhaustive. I plagiarized this list from AORN. Their list was more robust. I tried to keep it a little shorter, but I want to say there was 2 additional columns almost of this length of different types of symptoms that have been reported from staff on exposure to surgical smoke. So again, I talked about at the beginning of this presentation, that the raising awareness, and it is growing rapidly, but there's still a lot of work to do. NIOSH did a survey with relation or respect to laser plume, which for those of you who've been around a while know that 20 years ago, 95% of the time that a smoke evacuator was even discussed for use during surgery, it was during lasers. And today we're talking about it 95% of the time during electrocautery. But this particular survey was done with respect to laser procedures, which has more of a legacy foundation on awareness. And even then, only 49% of those surveyed cited ever having been trained effectively on the hazards of laser plume exposure. So there's certainly still work to do in that respect. And again, we're addressing that today. That number is getting a little bit smaller today. So we talked about the cancer risk, and again, this is that irrefutable bubble that you can really talk with anybody about without trying to sound too intelligent and because there's always going to be somebody in the room smarter than we are, and talk, with spread of infections and diseases and how can we quantify? Well, we can have that conversation, but again, do we need to say that we need to evacuate smoke? That's like an added flavor, like icing and decoration on, yes, we need to do it because this is possible. But what we know is inquantifiable, again, is the same chemicals that are in cigarette smoke are in surgical smoke. The surgical mask does nothing to block the large majority of them. And the pulmonary alveoli is doing the heavy lifting if we don't evacuate the smoke, which can lead to disease similar to exposure to cigarette smoke. So what are some of the other risks? I mean, I mentioned some risk to patient and environment of care and some other things during, the different flavors that an N95 will not specifically address. One of those is reproductive risks, and the reproductive risks is sort of a new addition to the CEU program, and a topic that is not well understood. A lot of it was conjecture for many years with me and my colleagues. We would talk about the newborn baby's first breath when they come out. That smoke could still be in the air, and they're breathing it in from their mother's burnt tissue. Certainly that's not chronic exposure, but if it's carcinogenic, do we want a baby to breathe that on their first breath? Probably not. That's a patient hazard. You have the significant other in the room of the woman who's giving birth, and even the woman who's birthing the child isn't often under general anesthesia, so they're breathing in the air from the room. The significant other is breathing the air from the room, and that smoke is going around in the room. Some other things to consider for you folks as nurses in the room is that many of you are of childbearing years and are still looking to become pregnant, and they have shown that there's certain chemicals in surgical smoke that can reduce fertility significantly. One of those, and even cause reproductive risks from exposure to these chemicals and carcinogens. Certainly, in during term of pregnancy, they've shown some negative effects, which are listed here. And one of those being a chemical called PCE, which is a known carcinogen to humans, is in high concentrations in the cauterization of abdominal tissue, which coincidentally we're cauterizing during a C-section. So it's sort of comes full circle again. All this can be minimized by using a smoke evacuator. Risk to patients, another viable consideration that an N95 again won't address, but it is on the table. Even in laparoscopic surgery, and there are the studies out there talking about the potential for surgical site infections to be potentiated by surgical smoke. Again, how do you quantify that? I don't know that they really can, except to maybe measure SSI rates in a hospital over a long period of time. For 5 years, not using smoke evacuation, have those rates, and then use it for 5 years and measure it. Those studies are probably underway. There may even be some that have been done in the last couple of years since I really put my scholar hat on in this field, that expound on that issue more. But it's definitely a topic of discussion. The spread of the plume with the port site metastasis that I mentioned earlier, and with the spread of cancer from one part of a patient to another is on the table. We talked about some of the exposure for folks that are in smaller subspecialties of surgery where they're not under general anesthesia and they're breathing in the air in the room. They're still exposed if we don't evacuate the smoke from the source. But then in laparoscopic surgeries, you have the high buildup of carbon monoxide in the pneumoperitoneum that as we continue to cauterize in a closed environment, if we're not continuously removing the plume throughout the surgery, that buildup and then of the carbon monoxide is then being sucked into the patient through their bloodstream and can cause issues with post-operative recovery and potential toxicity to that patient during surgery. And these are all peer-reviewed journal publications. This is not my conjecture. And again, these studies are all available to you on request. So, I added this in last year, 2 years ago in wake of COVID. We all probably got sick of hearing the term coronavirus and COVID, but it was a real world issue, and no more so than for those of you in patient care. I can't imagine how your worlds were rocked by this topic, so I don't touch on it lightly. I mean, I had a few inconveniences of a few stores being closed and things, and my business got slow, but I was in no way affected the way you were. So I don't touch this topic lightly. But there was the discussion, okay, so is COVID in surgical smoke? There's a lot of research that was done out there. I read some that said probably, I read some that said yes, but it didn't matter, and I read some that concluded no, probably not. I don't know what the current consensus is. What I can tell you is the studies that I read that were the most exhaustive concluded that surgical smoke may carry or would likely carry coronavirus, using the fact that we have isolated and identified HIV, HPV, and TB, other AKA other viruses in prevalence within surgical smoke. So that became the precedent as to why. I can also tell you that groups like SAGES and the ACS, the American College of Surgeons, who had otherwise been relatively silent on the topic of using smoke evacuation, in the wake of COVID became actively prominent in suggesting that smoke should be evacuated no matter how much during surgery. And that is on ACS website last time I looked, which was 2 years ago in all fairness, but it was a huge change in position, and that was, again, in response to the pandemic. So all that aside, that's why you evacuate surgical smoke, why it's the responsible thing to do. And I hopefully have outlined that, you know, to some level, giving everybody a consensus that we're ready to move into how do we address the issue. And there's a lot of ways to address the issue. There doesn't have to be a cookie cutter approach, and there's very cost effective ways to address it. There's ways to appease surgeons' concerns that most of you have probably had the experience of being exposed to. You know, the systems are too loud, the pencils are too fat, the buttons are too hard to press, the smoke evacuators getting in the way, the nozzles sucking up fluid and tissue, I can't see very good, etc. The list goes down the line. Or it's just too expensive, the facility doesn't want to pay for it. Well, in the wake of legislation, they're sort of being forced to pay for it, but we can still, if you do the approach the right way, and you really look at the different subspecialties, you develop the policy in a proper manner, and you address the individual needs of the specific type of surgeries and preferences of those in those particular operating areas, it can be very cost effective to address surgical smoke versus just saying we need a $25 pencil on all 1,000 procedures we do every year. You do the math, boom, this is a big expense. And I've had many OR directors come to me with that concern. And then when we were done, the fraction of what they actually had to spend to implement an effective policy was 10, 15% of that blanket number that they thought they were going to be held to. So that hopefully provides some level of encouragement, especially if you are a nurse looking to gain momentum from management, or if you're in management and this is something you're considering instituting in your facility. So staff protection. We talked about why it's important to protect the staff. And you know, you want to do so in two different tranches. You have the tranche of open procedures and you have the tranche of laparoscopic procedures. An ideal smoke evacuation equipment would be able to handle both types. There are devices that can be used in laparoscopy that do not require a suction device. Those devices tend to be simple to use, but they're not necessarily very effective. They don't provide any type of assistance with post-operative disinflation. You still have to push on bellies and do some things to manipulate. But there are smoke evacuators on the market that have effective modes for open procedures, and that same piece of equipment has a mode to effectively handle laparoscopic surgeries. So those are important to consider, and we'll touch more on that in a moment. It enhances surgeon performance too, and that's on the table with open procedures, and that the doctors need to see clearly, and you want them to not have smoke billowing in front of them, but that's more pronounced clearly in a laparoscopic environment with a closed pneumoperitoneum and the buildup of that smoke throughout the surgical procedure, inhibiting their ability to see. And the longer you have to wait for them to be able to see clearly on the cameras, the longer the procedure takes, the more the patient is under anesthesia, the longer the patient is being exposed to the smoke and absorbing it into their bloodstream, et cetera, et cetera. So having an effective smoke evacuator for laparoscopy that's continuously and consistently removing the plume throughout the surgery is very, very important to consider. And it certainly helps with the surgeon being able to see clearly. while again minimizing that patient's exposure to absorbing carbon monoxide throughout the surgical procedure. Coming back to COVID quickly, ECRI put out, and the ECRI, for those who aren't familiar with the body, is sort of like the consumer reports for clinical engineers and biomedical personnel in healthcare settings, and probably other settings too. I'm only familiar with their work in the healthcare segment, but they deal exclusively in this area. And they went on record with a hazard bulletin that went out into the field, talking about the importance of using a smoke evacuator with near 100% efficiency on particles down to 1.2 micrometers, which is the equivalent of 0.12 microns. Again, 0.1 is what we talked about being the standard for ALPA that's on the market today. Surgical masks, again, are 5.0 micrometers or 5 microns, significantly higher, larger particles. This biomedical engineering firm is putting out hazard bulletins recommending high-level filtration, which is what is standard in most smoke evacuators. Not all ALPA is created equal, and I'll touch on that shortly. So what guidelines are out there? And I apologize for this. And hopefully, I don't know if anybody can chime in and let me know if you can see me moving over to a different presentation. I know some softwares, some of these net meeting programs allow you to do that, and other ones will actually stop sharing the screen. So I hope you can all see this, because I'm going to move over to an updated legislation map in the United States. The map that I had originally on the screen, you'll see, is a little bit different as of April 2022. This new one that I just toggled to is as of August 2023. The most recent state that passed legislation requiring the use of smoke evacuation on all surgical procedures in hospitals and surgery centers was the great state of Louisiana. That bill was signed by their governor in June of this year and went live August 1st of this month. Other states that have passed legislation are in dark green on the map, and all of these states pretty much have identical language requiring the hospitals to create a policy, or the surgery centers to create a policy on addressing surgical smoke, and then executing said policy. So it's kind of a two-part legislation. The creation of the policy can be very simple. My company offers assistance. If you need assistance, feel free to reach out to me in any way, and I'm happy to help you piece one together. AORN has available resources for you, and there's ways to do it, again, to design it to be cost effective versus just a broad stroke approach on an expensive solution. There's cost effective ways to go about compliance with this state by state legislation. And I would imagine that this map will continue to color in as the months and years go by, as the precedent has clearly been set. So on a more broad stroke, what are some national guidelines? We know 14 states and a half dozen others have, enacted or pending legislation. But what about, on a broad stroke? Well, the OSHA does have some standards that do apply to surgical smoke. For instance, the OSHA General Duty Clause, that the workplace should be free from any recognized hazard, which we believe surgical smoke is clearly recognized. There is also the personal protective equipment, which I mentioned earlier. And then there's the OSHA E tool, or the surgical suite E tool, that says to, quote unquote, evacuate all surgical smoke, no matter how small, which is also on OSHA's website. So they do have some legislation that would be more broad stroke versus state by state. And then the NIOSH has their CDC HC11, or Hazard Controls 11 report that was done 25 plus years ago, that talks about how important it is to evacuate surgical smoke. We do have some other professional associations recommending the use of smoke evacuation, like the AORN, who's been a longtime champion for smoke evacuation regulation. I'm a huge fan. I'm sure most of you are. Vanjie Dennis, former president. I'm well acquainted with her work. She's been tremendous. Folks like Kay Ball, Brenda Ulmer, Andrea Dyer. I mean, the list goes on and on of AORN members predominant AORN members that have just done great work in pushing smoke evacuation, both through states as lobbyists and in their own respective places of employment, making smoke evacuation a standard of care. I remember Gwinnett Medical Center in Georgia, where Vanjie worked, is probably the first health system in the United States that actually had a smoke evacuation policy and complied with it across the board on all surgeries. So this isn't new, but it's become, that they were the very first, and there's many, many, many more that have done great work in coming along her side, and now the states are finally adopting this, kind of helping nurses get what they've been asking for, and AORN has been a great champion for that cause. The Joint Commission, formerly known as JCO, has some standards, including an environment of care standard, element of performance, number 9, listed here on this EC, that requires hospitals to minimize risk associated with hazardous gases and vapors, including quote unquote vapors generated by ... cauterizing equipment. In other words, we're saying surgical smoke without using the word surgical smoke. And so that is an element of performance that some JCO reps or Joint Commission reps have cited facilities that I know of for not using it. This is all pre-states having legislation in place. I mentioned the OSHA Surgical Suite E-tool. I can tell you that other nursing bodies throughout the globe have been recommending IFPN, ACORN, just so many that smoke should be used. And I already mentioned American College of Surgeons and SAGES being surgical bodies that are recommending the use of smoke evacuation during surgery. So AORN has some guidelines for surgical smoke safety that can be downloaded and published with some additional resources. Again, I can help you sift through some of those. I can help facilitate getting them into your hands on request. But it discusses some of the different key components on how to go about evacuating surgical smoke, creating policies, instituting said policies, etc. That's kind of a big overview on the regulatory legislative front. And so diving into, putting the gloves on and how do we start addressing the issue, say we've created a policy, we require smoke to be evacuated, and I'll address some more on some tools that can be there, and I'll briefly scan over those. But when it comes to finding the smoke evacuator, we talked about having equipment that would do both open and laparoscopic surgery. This piece of equipment right here, you can see has 2 buttons on it. One is for open, the bottom button, the green one there, puts you in a laparoscopic mode, which sets the flow setting or the suction power at a predetermined ideal sweet spot, not to, so as to not compromise peritoneal pressure, which is of vital importance during laparoscopy, as you all know. Smoke evacuator, in addition to having 2 modes of operation, the suction power should be adequate, should be strong. One of the reasons for that, and I'll briefly touch on it, as briefly as a salesperson can do. As you can see, I like to talk, and I hope that's okay, because that's what I'm here to do today. But the smoke evacuation pencils, doctors use these, they cut, they coagulate, this creates a large amount of plume. But in doing so, if this smoke blade is too close to the nozzle, you end up getting fluid and tissue suctioning up into the line consistently throughout the surgery. And you also have issues with visibility as the surgeons are looking down, or the first assists are looking down and cauterizing. They can't see as clearly. It's getting in the way of the surgical procedure, which is what they're really there to do, is to perform surgery. Evacuating the smoke is sort of a secondary process. And so having a smoke evacuator that's strong and has a very strong suction power, and those machines do exist, they're few and far between, but they're out there. And if you have the right one, what that allows you to do is to use a longer blade in the same pencil. This particular pencil allows you to slide the blade out up to 1 full inch and still maintain a strong connection. So now you've reduced the accidental fluid and tissue suction. You've improved the surgeon's visibility, keeping them happy and allowing them to work consistently without stopping throughout surgery, and to also be on board with using smoke without interfering their desire to perform proper patient care. And again, having a strong enough smoke evacuator allows for that suction power to remain strong enough to grab all of the smoke even when you pull that out another inch. A lot of smoke evacuators, if you go out this far, if you go out much past 1 inch, the suction power deteriorates rapidly to the point doing this to accommodate the surgeon will allow for smoke to escape, and you'll still smell it, and that's not good. Then you're still exposed. Strong enough, again, suction power on the actual console will enable you the flexibility to do this on a preference while not compromising exposure. I hope I stated that clearly enough. And so with smoke evacuation, I also want to point out that I like to put things in bubbles, but pictures help me learn, and hopefully this resonates with someone. But smoke evacuation has 2 tranches as well. One is we use the term smoke evacuation, but it doesn't deal with the second tranche in its name. The evacuation is tranche 1. That's the first. We're evacuating the smoke from the surgical site to address all those issues that we mentioned earlier: environment of care, spreading of disease, ocular, respiratory exposure. What the second part, though, is filtering the smoke. We need to filter it. We pull it away from the surgical site, but where are we sending it? If we don't filter it properly, we're just moving it away from the site, but we're sending it somewhere else. So filtering it is that second tranche in smoke evacuation, which often gets, I think, overlooked as though it's commoditized, but it's not. Not all ALPA is created equal, and I'll touch on that here in just a moment. So, okay, smoke filtration should prevent contamination of the equipment, and this kind of ties in with where we're going with that filtration aspect. Not all ALPA is created equal. The ALPA that's in your smoke evacuators today, a lot of them are just traditional ALPA, and they do a good job, but is good enough? I don't know. I'll leave that for you to decide. But what I've come to learn after 16, almost 17 years with a competitor in this space before joining IC Medical is that the ALPA that I was selling for all those years didn't effectively block fluids from passing through the filter and contaminating the actual equipment that is continuing to be used on other patients for weeks, months, and years down the line. So there are hydrophobic filters on the market. Hydrophobic is just a fancy word meaning water can't pass through or blood can't pass through. It's important to note that surgical smoke, while it's warm, is smoke and vapor, but it's comprised of 98% water droplet. So it's warm and it's smoke, but it's water. And the smoke, as you use a pencil, you're down near the incision, and there's a lot of bloody procedures out there. Laparoscopic environments, humidity tends to be high, and that can carry pathogens that are in that patient and the carcinogens. As a filter in your smoke evacuator, if it is not hydrophobic, and using a fluid trap is important. A lot of you have probably seen it. This particular one includes a built-in fluid trap, but there's others where you can plug the fluid trap on top. That's good. That's one step. However, a lot of blood and fluid will still continue to hit and penetrate the filter wall, the membrane. And as it does that, if there's enough of it, it can ingress down below into the basket chamber where the filter is seated, and now your smoke evacuator starts to become contaminated with that patient's DNA. A lot of that DNA will decompose over time and pass right out the exhaust back into the environment of care. Again, I'm not an epidemiologist. I'm not going to tell you what that means, but it just shouldn't happen, which is why there are smoke evacuators that include hydrophobic ALPA, which prevents blood and fluid from ever passing through and contaminating the smoke evacuation equipment. So that's dealing with large amounts of fluid, but there's also the nanoparticles that we spoke about. They're in the plume, and they're very small particles that contain viruses and those fragments. So not all smoke evacuators are created equal with the ALPA in terms of filtration efficiencies either. We talked about smoke evacuation and ALPA, and even in the ECRI report where they published 0.1 micron or 0.12 micron on this particular one. That's great, but what we know, and hopefully you can see my presentation as I toggle over, but I'm going to move over and show you a slide that, and if you don't see this, I can get it to you offline. But what we know from research is that most viruses like influenza, SARS-CoV-2, and HPV are half the size of 0.1 micron or twice as small at 0.5 micron. While competitive filters, most filters on the smoke market only show the 99% plus efficiencies to .1. What happens when a virus is .06, like SARS-CoV-2? They don't say. Some smoke evacuators have gone, companies have gone so far as to have their filters tested, ours being one of them. We will filter down to 0.3 micron with 99.999% efficiency. So we're covering all known COVID, HIV, and SARS-CoV-2 particle sizes with that almost 100% efficiency. So that, again, is one of the reasons why not all ALPA is created equal, and there are some things that you can consider as you're moving towards selecting the proper product to put in place in your facility. We talked about, I want to leave ample time for questions and answers, so I'm going to try to skim through a lot of it, and I know I'm probably going ad nauseum with a lot of this. Hopefully some pieces that resonate with you specifically into your real world environment will be a topic that you've taken note of, and you can certainly address that issue if you need me to expound on any of it. All of it is available. Everything that I've said along with the references are cited throughout this presentation, including this two important pieces that I covered on the filters being hydrophobic and preventing blood and materials from contaminating the equipment, and also the importance of having that near 100% efficiency on viruses that are smaller than .1 micron. That is covered here for you in detail in this presentation. Noise control, that goes without saying. We talked about some of the complaints that are commonplace in exposure, and certainly having a noise level that is acceptable to the staff is important. Using a pump can keep the frequency low versus a brushed motor. That can be a useful thing to consider when you're looking at a smoke evacuator. And then I always recommend keeping your smoke evacuator suction power as low as possible at the lowest setting, and increasing only as needed, i.e. we're still seeing or smelling smoke. That will help keep the subsequent noise to a minimum. Obviously, you want the smoke evacuator to be efficient. You want it to have intuitive interface for the staff to know, and you want your smoke evacuator to turn on and off automatically so that there's no perioperative staff involvement in the use thereof. So financial sustainability, if we have a good smoke evacuator in place with a strong power and a strong filter, we want it to be cost effective too, right? I know of products that are on the market for laparoscopic that recirculate air throughout the laparoscopic procedure, and they do a great job, but the tubing set is $200. So, how are you supposed to rectify that? You can't use it on every lap chole. It's impractical. And so there are cost-effective ways to do it. My company's tubing set for laparoscopic surgeries can be as low as $9 on a per patient basis. So there are cost-effective ways to maintain a high level of performance and safety while keeping the cost minimal. Another thing to consider in financial sustainability is a lot of our procedures, and I know Gwinnett Medical Center in Georgia that I alluded to earlier was a predecessor in this arena. And that is using what's called an inline filter, where you just put a filter in your suction line between your canisters where the fluid drops off and the source of suction origination, whether it's a high pressure suction hose coming from your ceiling or a wall suction or a boom mounted vacuum. Having an ALPA filter in the line will enable you to evacuate and effectively filter the smoke on procedures that generate a nominal amount of plume on a very cost-effective basis. These filters can be reused, changed once a week in the operating room on Monday morning room turnover, or when significant discoloration is noticed. But again, it can cover a large percentage of your procedures and be compliant with policies at the same time. And I love the adage here, the coined phrase, doing the right thing the easy thing to do, and certainly covering a large volume of your procedures is something that's cost effective, and blanket covering is one way to make it easy on you for sure. Keeping education and competency, in other words, getting all your stakeholders involved in the decision-making process is important. One way to do that is to offer a CEU program similar to this one to all of the staff and the technicians, the nurses, so that everybody knows here, when the rep shows up, or the reps for trials that you're doing, etc. They're not sitting there like, why am I here, right? I just want to get my work going. I got a patient care to address, and I've got my real world outside of this place that I need to address. I don't want to learn more about, I don't want to use the smoke evac. I don't want to brush up against the doctors. I don't, they don't, you have enough work to do. I mean, you're busy, you have a life. Let's make this simple. Let's get everybody on board so that everybody in the room, when a surgery is getting ready to start, all agree that, yeah, I want to use the smoke evacuation today. And then even getting the doctors on board with a policy, and having the staff enthusiastic about why it's to be used, so that we can get everybody on board, so that there's a path of least resistance and we're all doing the right thing together, because we all know why, and we have a vested interest in seeing the program of smoke evacuation being successful. So, to ensure that the operating room is safe, it is recommended, and you list here, you define the management of smoke evacuation, including sources and hazards. You talk about particle transfer in the operating room. I won't even go into a lot of this. This is stuff you can read offline. Considerations and monitoring compliance, that's important. There are checklists. I can provide those for you. I can show you where to get them. I can help you create one that's specific to the type of equipment that you have, or whatever that equipment is. Some checklists that each staff that comes in as a new hire gets trained on how to do it. We can help train them how to do it, how to check the filter when it needs to be replaced, how to change the tubing, how to hook it up, is there adapters, how do we set the flow, these types of things. Checklists that can be trained, make sure the whole staff has all been trained on it as part of the policy, and then maybe you do it again every couple of years or something like that. But these are checklists that can be used to help make sure that everybody not only knows why they're doing it, but that they know how to do it and how to do it effectively. And so, in summary, the harmful effects of surgical smoke are well documented. The benefits of using a smoke evacuation system are clearly defined and described in safety guidelines and in presentations like the one we just went through. By implementing a smoke evacuation system and a policy in your procedure, the staff, the patients, and everybody in the perioperative environment can be protected from the hazards and help prevent the harmful effects and spread of surgical smoke. And with that, I will hand it back over to Linda, and I appreciate each one of you. I look forward to hopefully answering or trying to answer some questions that may have originated.
Great, thank you, Richard. We've got a few questions that have come in. The first question is, what regulations are in place to protect healthcare workers from surgical smoke in the states without enacted legislation?
It's a great question. We did touch on it during the presentation, but I'll go back through that because that is an important question. And if I was in one of these states, not on this particular map because it's not updated in this presentation, but if I were in one of the states that didn't have legislation, I would be asking the same question. And again, OSHA does have some regulations that do apply. I can tell you there are many hospital systems in states that don't have legislation, that do have policies, that a lot of the folks, like Vanderbilt University is a great one in Tennessee. They have a policy that's required smoke evacuation for many years. Most of the staff don't even know there's a policy that's out there because nobody enforces it. Well, I shouldn't say nobody. It's not enforced carte blanche. So you might even be surprised that a health facility that you work for maybe even already has a policy requiring it, that if you print that up and bring it with you, they'll be like, oh, wow, I didn't even know we had this. Hard work's done. Let's find a solution. But then you have, again, OSHA, you have the Joint Commission with environment of care, elements of performance requiring the use of smoke evacuation. You have regulatory bodies and standards organizations, like ANSI and AORN and others, giving you some backbone, but certainly using Joint Commission and OSHA along with the precedent set by other states would hopefully help anybody who is interested push the initiative forward in their respective facility.
Okay, and another question here is, what if our doctors refuse to use smoke evacuation products?
That is a great one. that is a great one. A lot of doctors will. I think what's important at that point is to, why won't you use it? what is the real objection behind the objection? The first objection we get from anybody really isn't the reason why. It's just their knee-jerk response from a pain point that's probably deeper that they don't want to dive into for whatever reason. And so asking the why behind the why, I think, is vital at that point. I think a lot of times what you'll find is that, it's the smoke evacuator was too loud, the pencil was too fat, yeah, the buttons were too hard to press. The suction nozzle that we talked about was too close, getting in the way, sucking up fluid and tissue. We couldn't see clearly. The tubing was dragging on his or her wrist and making it cumbersome. We hear that word all the time. And those are all issues that have presently been addressed in today's technology that's available on the market, that I think we can easily show them something that's improved upon that pain point to a point where we can satisfy the need there.
Okay, and a question that's just actually come in is wall suctioning efficient as smoke evacuation?
Great question. Hands down, no, it isn't. It's a small diameter, right? I mean, you might have, and you'd have to test your suction depending on how old your hospital is or how strong the suction is. I mean, coincidentally, one of the things that can reduce suction over time, if you use a wall suction line intentionally or just inadvertently, accidentally sucking up plume as you're scavenging fluid over years, you create a clogged line, a clogged artery. Surgical smoke is 98% water. When it's warm, it's smoke, but when it cools, it condenses, moves back into a solid state, and now that open suction line that the hospital was built with 15 years ago or 5 years ago, instead of it being 10 millimeters, maybe it's only 8 millimeters in diameter in certain points, because all of that smoke that went unfiltered went back into the wall, clogging it as it condensed and cooled, and now you're starting to lose suction, which just makes the answer to that question even more difficult to answer. But if all things are perfect, it's a brand new hospital with a strong suction, the suction power can be strong as long as you're relatively close. I think the further, obviously, you move away with some of the suction lines because of how narrow they are at the nozzle or the tube, the suction performance won't by any stretch be near as effective as a high-powered smoke evacuator. It has its limitations, but it is an effective solution. And it is one that a lot of hospital systems, including AORN, are even advocating. And I can, hopefully this is moving over as I toggle yet again, but here's a wall suction configuration that you can see. You've got your fluid canister devices, you got your wall regulator, and you have this reusable inline filter in the line. Sometimes this filter is positioned between two canisters, just depending on the type of configurations that are in place. They're all different, but they can be placed. I've yet to run into a customer where we couldn't find somewhere to put it in the line to effectively grab it. And you can still use an all-in-one smoke evacuation pencil. Some of them come with the blue rubber connector on it that'll hook to a suction canister. So instead of having to go out and buy all new equipment, you have this in place. The one drawback to this configuration is simple and cost effective as it is. It will run the whole time. We're using a smoke evacuator. We can minimize the running to only when the cauterization is activated and have it turn on and off automatically. Wall suction is obviously going to provide consistent suction throughout the entire procedure. So you have the subsequent noise running through the air running through the nozzle, which could be an impediment to some.
Okay, that's great. Another question that's just come in: is the use of remote surgical procedures that are using surgical smoke tools increasing in the US?
I'm not even really sure what that question is, so I'm going to have to play dumb on that unless somebody can expound on it. On remote surgical procedures, are we talking about like Da Vinci robots, or what are we asking?
I will wait and see whether that attendee responds. In the meantime, I'll give you another question. Oh, hang on. He said yes.
Da Vinci? Yeah, it is. Yes. Yeah, you're running into a lot more of that. But there are fancy solutions for evacuating smoke on Da Vinci procedures, but the reality is it's just a pneumoperitoneum like any other laparoscopic procedure as it relates to evacuating the smoke. And the solutions don't have to be fancy just because the modality of surgery is fancy. I mean, you can still use a an effective smoke evacuator with a $10 tubing set and be just as effective at managing the plume as you would be with a $200 tubing set.
Okay, perfect. Well, we are coming up to our hour, Richard. So thank you so much for your time
Welcome.
today and for such an informative presentation.
My pleasure.
If anybody has got any questions, are they okay to email you directly, Richard?
100%. Yeah. In
Okay.
fact, I meant to pull this up earlier. I just made this quick slide here. I can certainly share this with you, Linda, and you can pass it on to whomever would want to see it. But there's my contact information there on the screen. And if, by all means, funnel through to Linda and the team at OR Today, and they can get it to me, or feel free by all means to reach out to me directly. I am more than happy to help any way that I can.
Perfect. Thank you so much, Richard. And I'd also encourage people, attendees to visit the IC Medical website so you can learn more about the products they provide to the industry. As promised, the answer to today's trivia question is brown, so congratulations to our winner, Rosemary Gaylord. And just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. Now, you must complete the survey to receive your certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@ndpublishing.com. Please visit ortodaywebinars.live for more details of all our upcoming webinars and, of course, complimentary registration. Thank you all for your time today, and I hope you enjoy the rest of your day.